Good morning, everyone. I'm Dr. SHIRODKAR. I'm a cataract and refractive surgeon from Narayan Nethralaya, Bangalore. So before we get into the nitty-gritty of the subject about different machines which are being used, I think it's essential to understand which machine and which procedure should be used for which patient. So at our institute, we firmly believe that every procedure needs to be customized to every patient, not just based on the topography, but also based on the patient's internal aberrations, which are unique to each eye, based on the patient's lifestyle, which is unique to each patient. So with that in mind, every procedure needs to be customized to every patient, and with increasing number of surgeries available, this becomes more and more difficult. Also, with the increasing demand for a spectacle-free vision, it is important that customization of the treatment is done for each and every patient. So with this in mind, let us begin with the preoperative evaluation. Obviously, it manifests in cycloplegic refraction, and slit lamp evaluation is mandated for every patient, followed by corneal topography with the PNS scoring. The internal aberrations are something that we document for each patient so as to decide the type of procedure which is to be performed. Tolerance test and Miles test to determine the dominant eye, especially for patients in the presbyopic age group. Dilated fundoscopy. The scotopic pupil size to determine the size of the optical zone. For soft contact lenses, we usually advise the patients to discontinue them for up to a week prior to taking the measurements, and for rigid contact lenses up to 3 weeks. Dry eye evaluation is, at our institute, it is mandatory for every patient because we find that it affects not only the postoperative discomfort in forms of postoperative dry eye, but also affects the visual outcomes to a certain extent, also leads to increased risk of glare and halos. So this is something that we perform for every patient at our institute, along with strabismus assessment and ability to tolerate anisometropia. So unfortunately, there's no specific literature on, although there's a lot of literature on the different types of procedures which are available, but there's no specific literature on what kind of procedure needs to be performed for what patient and an algorithmic approach that needs to be followed. So we've attempted to devise this. What we do is for a patient who's aged less than 40 years, the first thing that we look at is the corneal aberrations. If the corneal aberrations are low, with a low coma, low spherical aberration, the angle kappa is less, with a low mesopic pupil size and a normal topography and pachymetry, we look at the patient's lifestyle. If the patient is into contact spots, it is better to go for a flapless procedure such as SMILE. If the patient is not involved in any contact spots, you can go for a flap-based procedure. A wavefront optimized treatment is sufficient for a cylinder less than 0.75. You don't need to worry about treating the topographical abnormalities. Whereas if the corneal aberrations are high, if there's high coma, high SA, the pupil size is greater, the patient has a larger cylinder, we need to assess if the patient acceptance is less or more than the corneal cylinder. If the patient acceptance is less than the corneal cylinder, we understand that most of the aberrations are coming from the corneal surface and a topography-guided treatment is mandated in these patients. If the patient acceptance is greater than the corneal cylinder, the patient is likely to have more internal aberrations, and this is what needs to be treated with a wavefront-guided treatment. Furthermore, if a patient is not suitable for an excimer laser surgery, if the patient has an RSP of less than 300 microns, we look at the ACD and the endothelial cell count to see if the patient is a suitable candidate for a phakic IOL. Whereas if the corneal thickness is between 475 to 500 microns, the RSP lower than 300 microns with other refractive surgeries, and the patient has topographical irregularities which can be treated with a surface ablation procedure, and the patient is not into any contact spots, we can go ahead with surface ablation or PRK or trans-PRK. Now, if the patient is greater than 40 years, in addition to the tests that we've already described, the patient is, we also subject the patient to some additional tests, just a tolerance test, to see if the patient can tolerate a spherical addition of over the non-dominant eye. And we also assess the DLI and PNS, that is the dysfunctional lens index and the pentacam nucleus staging. If these are found to be normal, the patient, if he's a myope or an emetrope, is a good candidate for a monovision LASIK. Whereas if Presby LASIK can be considered as an option for myopes and emetropes. You can go ahead with a hybrid Presby Max, which has a component of monovision super added over a multifocal ablation. And for hyperopes, we can go ahead with Supracor, Presby Max Symmetric, Custom Q, and Presbyon. Whereas if the DLI and PNS are impaired, then one needs to look at lens-based refractive procedure. So we go ahead with a refractive lens exchange. The patient is a good candidate for a multifocal IOL if the photopic or mesopic size is between 2.5 and 4 millimeters. The patient has low level of higher order aberrations and a normal retinal evaluation. If these are found to be abnormal, then it is better to go ahead with a monofocal IOL or monovision based on a lens-based procedure. Thank you.
That was a very extensive algorithm.
Thank you.
It was nicely presented. Would you like to measure the axial length pre-op? Because that was not there in your
For
pre-op
which
assessment.
particular?
Would you like to
We
measure?
don't routinely measure the actual lengths unless the patient is in the.
Would you like to? Why would you like to measure the axial length? See, you would like to measure the axial length pre-op because of two reasons. One is many of these patients are coming in for getting rid of their glasses for occupational needs. They want to join the army or the air force, and then there is a cutoff of the axial length. So if you do the treatment without measuring the axial length, then they go back and there they measure the axial length. Though they are hemetropic 6'6",
Correct.
they can get rejected, and then they are disappointed. They come back and start fighting with you.
Absolutely.
The other is basically to distinguish between regression and progression. Okay, so when you do a corneal-based refractive procedure, you can have regression, and many of these young myopes progress also. So when we measure the axial length, we can clearly show them if there's an increase in the axial length. We can say it's an increase in your myopia, and this is progression of your myopia. And the procedure which we have done is perfectly normal and stable. The other aspect is, of course, in regression, the axial length is almost the same, but you can have surface changes, your topography changes, so that's important. And now with the Visumax 800, of course, we do biometry anyways because we need the iris registration from the IOL Master 700 for cyclotorsion compensation on the Visumax 800. So that's one thing. And the other thing that you all do in your institute, but you didn't put it in your pre-op, Dr. Rohit talks about it all the time, is a psychology coach to profile the patient whether they are suitable for refractive surgery or not.
Absolutely.